Let me ask Dr. Bocchini to kick off the session on Japanese encephalitis vaccine. Following the discussion from Intercell Biomedical, we'll open it up for some questions before moving on to the grade discussion.
Good morning. I'm pleased to start this discussion of the use of Japanese encephalitis vaccine in children with an overview of the work of the work group and some background information which provides you the key issues that will come before the ACIP today. Inactivated viral cell culture derived JE vaccine, termed JEVC, is the only JE vaccine licensed and available in the United States. In 2009, JEVC was licensed for use in adults 17 years of age and older. On May 17th this year, the FDA licensed JEVC for use in children 2 months through 16 years of age. So today we will present the evidence review, the grade evaluation, of the evidence and proposed recommendations for use of JEVC vaccine in children for discussion by the ACIP and then a vote. Now, JEVC Ixiero is manufactured by Intercell Biomedical. It's distributed in the United States private market by Novartis Vaccines, and it is indicated for the active immunization to prevent disease caused by JE virus. The dose and administration is listed here. For children 2 months through 2 years of age, it's 0.25 ml. For children 3 years of age and older and adults, it's 0.5 ml per dose. The primary series is 2 doses administered 28 days apart. Now, there is no efficacy data for JEVC. The availability of several effective JE vaccines in Asia made a comparative efficacy trial difficult to perform. However, there is an established immunologic correlate of protection. It's the JE virus 50% plaque reduction neutralization test, and a titer of 10 or greater is considered to be protective against JE infection. Now, JEVC was licensed in adults based on non-inferiority trial of neutralizing antibody response compared to a licensed mouse brain-derived JE vaccine, JEMB, and it was licensed based on a proportion of JEVC recipients who achieved virus PRNT50 titers 10 or greater, as indicated as a correlate of protection. Now, this vaccine, JEMB, had a 91% efficacy in a randomized controlled trial in over 65,000 children in Thailand in the mid-1980s. During the licensing process of JEVC in adults, safety evaluations were done on approximately 5,000 adults in the clinical trials, and since licensure, over 300,000 doses of JEVC have been distributed in the United States. This is a review of the ACIP recommendations for JE vaccine. In June of 2009, ACIP approved recommendations for the use of JE vaccines in U.S. travelers, including JEVC in adults 17 years of age and older, and a continuation of the recommendation for the inactivated mouse brain-derived JE vaccine, JEMB, for adults and children 1 year of age and older. In February 2011, the ACIP approved recommendations for a booster dose of JEVC. Now, as you heard, JEMB is no longer manufactured or available in the United States. During the time period of 2002 through 2009, it's estimated that approximately 2,000 to 3,000 doses of JEMB were distributed to pediatric providers each year, it's difficult to translate that into the number of children who are immunized because non-pediatric providers certainly could have given the vaccine to children, who were traveling, and then this vaccine, JEMB, required 3 doses for the primary series. However, the options, the JEMB vaccine, the remaining supply became outdated. The date expired in May of 2011, so the vaccine was no longer available at all for children, and the CDC published in MMWR in that May options for obtaining the JE vaccine for children outside of the country who were traveling. So the JE vaccine work group was reactivated in October 2012. The working group has met 13 times to discuss issues related to JEVC in children. We reviewed the epidemiology of JE infection in travelers, the safety and immunogenicity of JEVC. We performed a grade evaluation and developed proposed recommendations, which we will present today to ACIP. We've given 2 previous presentations to ACIP on this topic, the first in October of 2012 to indicate the work group charge and its plans. And then in February of this year, we discussed Japanese encephalitis virus and its infections and sequelae, and the use of JE vaccine in travelers. I want to thank the members of the work group. This has been a very active work group with contributions from each of its members. Particularly want to point out Laurie Rubin, the other ACIP member, for his help, and Mark Fischer for keeping us on task throughout this process. So today we will first hear a presentation from Intercell Biomedical on the safety and immunogenicity of JEVC in children. This will be a review of the data that was submitted to the FDA, which led to the licensure of the vaccine. It will be presented by Katrin Dubischar-Kastner from Intercell Biomedical. Following her presentation, there'll be an opportunity for questions from the ACIP. Following that discussion, Mark Fischer will present the grade evidence, the review of evidence in grade for use of vaccine in children, and then he will present the proposed recommendations for use of the vaccine in children, followed by discussion and then vote. There will be no VFC vote for this vaccine. So next, Dr. Dubischar-Kastner.
Thank you. Good morning, and it's really a pleasure to be here and be able to present the pediatric data that led to licensure of this vaccine to you. As has been pointed out, the manufacturer of IXIARO is Intercell. However, you will see a new name on this slide here, and I'd like to just inform you that we recently completed the merger with a new to form a new company called Valneva, and in the midterm, the manufacturer's name will be transferred to this new name that you already can see on the slide. So in total, I'm going to present data from 3 clinical trials to you today that were conducted leading up to licensure of IXIARO. This was one phase 2 study conducted in Indian toddlers where we looked to confirm the dose of the vaccine in the ages from 1 year to 3 years. And then we'll show data from 2 phase 3 clinical trials, one conducted in traveling children from endemic areas, Europe, United States, and Australia, so children that were traveling to areas in Asia. And then the second study I'm going to present on is a large phase 3 study that was conducted in the Philippines. Starting with the phase 2 trial, as I mentioned, the study had the objective to confirm the dose of IXIARO used in children aged 1 year to below 3 years. The study was a randomized controlled clinical trial in 60 healthy toddlers, and these children received either an 0.25 ml dose of IXIARO on days 0 and 28. This represents half of the adult dose, or an 0.5 ml dose of IXIARO again on day 0 and 28. And then we had a control group who received a vaccine produced on mouse brain. This is licensed under the trade name Encephalitis and is produced in Korea. The vaccine is manufactured to a similar technology than the formerly US licensed JVax. And this was given in a 3-dose schedule, day 0, 7, and 28. The study had a follow-up up to 28 days after the second vaccination and looked at immunogenicity and safety. So let's look at the immunogenicity results first. In that study, we've seen relatively limited pre-existing immunity. Day 0 before the vaccinations, around about 4% in both of the IXIARO dose groups had evidence of neutralizing antibodies against JE. On day 28, so 4 weeks after the first dose of IXIARO, the seroprotection rates ranged about 60-70%, and within 4 weeks of the second dose of IXIARO exceeded 95% with both of the doses of vaccine. Looking at the geometric mean titers, in response to the complete immunization schedule here on day 56, we see that the half dose of vaccine and the full dose of vaccine did not really differ in terms of immunogenicity, and were also very well comparable to the neutralizing antibody titers induced by the three-dose course of the mouse brain-derived vaccine. So from the immunogenicity data, there was no indication that a higher dose would be of benefit for those children. Looking at the safety results for the half dose and the full dose, we see that both of the doses were well tolerated. Looking at the overall adverse event rates, about 12% in the subjects who received the 0.25 ml dose of vaccine, and about 20% with the full adult dose of vaccine. The only reaction that was seen in more than one subject was injection site tenderness, and there were no serious adverse events in this study. So based on both the immunogenicity and the safety results, we decided to carry the 0.25 ml dose forward for development in this age group. The second study I'll present data on is the phase 3 clinical trial in traveling children. This study was a challenge to conduct because of the population that had to be enrolled. Notoriously, travelers tend to present very late for their immunizations, and it was really very challenging to recruit children who were able to get both vaccinations and who would be present for a follow-up visit 4 weeks after the second dose of vaccine. The data I'm showing from this study are data from an interim analysis that covered 60 children. We enrolled the entire age group between 2 months and up to 17 years of age, and the study was conducted as an open-label, single-arm study. In terms of recruitment, we were able to recruit 5 children who had received, who were going to receive the 0.25 ml dose, and 55 children received the 0.5 ml dose based on their age. Follow-up of this study extended to day 56 and a visit at month 7. Again, looking at immunogenicity data first, as expected in this population, we did not see any pre-existing immunity, so no child with neutralizing antibodies prior to vaccination. And on day 56, with both doses of vaccine, the seroprotection rates reached 100%. And while the data at month 7 in this current interim analysis are limited to 18 subjects who had reached this time point, we see that all of these subjects were able to retain their protective titers. Looking at the respective geometric mean titers here, what we can see is that on day 56, we get GMTs in the range of 200, 300 with both doses of the vaccine. So no lower immunogenicity with the half dose. And as expected from the results that we've seen in adults, we see a decline in the neutralizing antibody titers between the day 56 and the month 7 time point. And the rate of the decline is comparable to that profile in adults. Now let's look at safety results in that study. The safety analysis is based on 60 subjects who received at least 1 dose of the vaccine. And overall, the primary endpoint for safety in that trial was the rate of serious adverse events or medically attended adverse events. In total, there were 3 children, or a rate of 5% for such adverse events. All of these 3 are actually medically attended adverse events. No serious adverse events occurred up to day 56. The overall rate of adverse events in the trial was 66% of children had any solicited or unsolicited adverse event. Now I'm going to look at the solicited adverse events first in the 5 children who received the 0.25 ml dose of vaccine. Data are limited here, but we have 1 child with an injection site reaction after the first dose and 2 children who had injection site reactions after the second dose. The reactions we've seen were hardening and redness, and we've also seen diarrhea as the only solicited systemic symptom after both doses. Now looking at results for the 0.5 ml dose group, where the cohort of children is larger. These are local reactions to the first and second dose of vaccine. So after the first dose of vaccine, about 40% of children had any injection site reaction, and this rate was lower after the second dose with about 27%. Comparable to the local reactogenicity profile we see in adults, pain and injection site tenderness are the most common reactions, and the only reactions that occur in more than 10% of the subjects. Now, moving over to solicited systemic reactions, again, we see 42% of children having any systemic reaction after the first dose, and a lower rate with about 16% after the second dose of vaccine. Muscle pain and excessive fatigue were the most common reactions after the first dose, and are the only reactions that were seen in greater than 10% of the subjects. There was a low rate of fever, and fever was mostly very mild. So summarizing this study, IXIARO was immunogenic and provided protective antibody titers in both dose groups. All of the subjects developed protective titers at day 56. GMTs ranged in the 200-300 area day 56 and declined down to month 7. However, for the data, for the subjects we already have data on month 7, all of them retained protective titer levels. IXIARO was also well tolerated at both doses that were utilized in the study. The overall profile was comparable with that for adult data, for adults for solicited adverse events, and for unsolicited adverse events, we've actually seen fewer reactions than in adults. So with this, I'd like to move over to present the third clinical study, the trial that was done in the Philippines. This study looked at safety and immunogenicity of the vaccine, and it also included a little cohort where we again looked to confirm the dose in children aged 3 to 12 years. The trial was conducted as a randomized active controlled study, and the total number of subjects was 1,869 children. Again, we recruited from all age groups from 2 months up through 17 years of age. Maybe one thing to point out, the Philippines, while the country is endemic for JEV, does not have a JE vaccine licensed, and it's not part of the national immunization program, so we could recruit from all ages there. The treatment groups we had in this study are basically the IXIARO groups received either 0.5 ml of IXIARO if they were aged 3 years and older, and the 0.25 ml dose was again used for children from 2 months of age up to 3 years, and I mentioned a little cohort that received that dose of vaccine aged 3 to 12 years. We had to use 2 different control vaccines because we didn't find one vaccine that would be licensed in the United States and would be approved for the entire age range from 2 months of age up to 17 years. So we ended up using Prevnar as a control vaccine in children aged below 12 months, and the schedule was vaccinations on day 0, 28, 56, and the 3rd or 4th dose at the last study visit. The 28 dose was administered to children who were below 6 months at enrollment. And for the age group aged 1 year and older, the control vaccine was Hevrix. The study again had a follow-up to day 56 and at month 7 for immunogenicity and safety. The primary endpoint of the study was a rate of serious adverse events and medically attended adverse events up to day 56, and immunogenicity was addressed in a subgroup of patients. This is just a brief study scheme because of the different vaccination schedules we've used in the IXIARO and the control group, and I just wanted to walk you through the safety data collection and the amount of vaccinations we've had in the study. So basically, IXIARO was given at all the ages and both doses on day 0 and 28, and after each of the vaccinations, we had a subject diary that covered 7 days following vaccination. For Havrix, as I mentioned, the first dose was given at study start, so we had a subject diary for the first dose. The second dose was given at the very last study visit, and there was no additional safety follow-up after 60 minutes after that second dose. And for Prevnar, subject diaries after the first dose and the 28 days dose, if it was administered, are included in the analysis up to day 56 data. This diary card for the third dose is included in the analysis of data up to month 7. And again, the last dose administered at the last study visit, we do not have any safety data collected for this dose. Now, this slide shows you the age distribution of the study population. Overall, we recruited 131 children aged between 2 months and 1 year, and the comparator in this age group, as mentioned, are 64 children who received Prevnar. The age group 1 to below 3 years is the largest cohort in the study. We had 640 children who received IXIARO compared to 213 who received Havrix. Then the age group 3 to 12 years, at the licensed dose here, 300 children who received an 0.5 ml dose compared to 100 who received Prevnar, and finally 240 adolescents who received IXIARO. Let's look at the seroprotection results first. This is again throughout the study, looking at the 0.25 ml dose and the 0.5 ml dose. As you can see, we have relatively limited pre-existing immunity with the younger age groups receiving the 0.25 ml dose at about 5%. This rate is obviously higher with the 0.5 ml dose where children go up through adolescence. And on day 56, in both vaccination groups, we have seroprotection rates exceeding 99% or reaching 100% with the 0.5 ml dose of IXIARO, so very good response. And at month 7, we see that protection persists in about 88% who have received the 0.25 ml dose of vaccine, and about 95% with the full dose of vaccine. Because of the pre-existing immunity, we also looked at the rate of subjects who would achieve seroconversion, so an at least 4-fold increase in PRNT50 titers, so neutralizing antibody titers. And with the half dose of vaccine, the 0.25 ml, this rate was exceeding 96% on day 56, and it was also around about 85% with the full dose of IXIARO. Looking at geometric mean titers with the 2 doses, so in the children aged 2 to below 3 years with the 0.25 ml dose, the GMT was 288, and the older age group with the full dose of vaccine achieved a GMT of around about 200. And again, we see as we follow the children through to month 7 that the geometric mean titers decline as expected. Now, moving over to present the safety data of the vaccine, and the way the next couple of slides are designed is that I'll first show you the results for children aged from 2 months to below 1 year comparing to Prevnar, followed by the same data for the age group 1 through 17 years of age and compared to Havrix. So the primary endpoint of the study, as mentioned, was the rate of subjects with any serious or medically attended adverse events, and the rate was very well comparable for the 2 vaccines, around about 40%, both for IXIARO and Prevnar. The overall adverse event rate of any solicited or unsolicited AEs was also comparable between the 2 vaccine groups, 84% for IXIARO and 87% for the Prevnar group. And Actually, there was no serious adverse event with IXIARO up to day 56 and one in the Prevnar group. These are the same data now for the children aged 1 to below 18 years. Again, the primary endpoint is very well comparable between the two vaccine groups, and as expected, we do see a lot less serious or medically attended adverse reactions with the older age groups compared to the infants. So 16 and 14% of children had any serious or medically attended adverse event to day 56. Again, there is no difference in adverse event rates overall for the two study vaccines. Around about 60% of children had any adverse event during the trial. And the rates are also well comparable if you look at medically attended or serious adverse events on their own. This is the data for the complete follow-up up to month 7 of the study, so long-term data. And again, we see that there's virtually no difference in the adverse event rates between the IXIARO receiving children and the group who have received the Prevnar. And these are the same data for the age group 1 to below 18 years of age. Again, no big differences or no pronounced differences between the children receiving IXIARO and Havrix for any adverse event, medically attended or serious adverse events. There was unfortunately one death during one of the studies. During the study, a 12-year-old boy who died following a suspected bacterial meningitis and pneumonia, and the underlying cause of death was believed to be a disseminated intravascular coagulation. The death occurred 4.5 months after the second dose of IXIARO, and it was reviewed by an independent data and safety monitoring board who concluded that it's very unlikely that this would have anything to do with vaccination. Now I'll move over to show you the solicited adverse events. First, starting with reactions, local reactions in children below 1 year of age. So if we look at the results for the dose 1, you can see that 19% of children had any local reaction within 7 days after the first dose, compared to 32% for Prevnar. The rates for local reactions are lower for redness, for tenderness, swelling, and hardening. For IXIARO compared to the Prevnar. And as we've seen in the other studies, we see fewer local reactions with the second dose of vaccine. 8% of children had any local reaction within 7 days after the second dose, compared to 18 for Prevnar. Looking at the data for the older age groups, about 14% in both the IXIARO and the Havrix group had any local reaction within 7 days after the first dose, and none of the solicited local reactions occurred in greater than 10% of subjects overall. And again, we see that with the second dose of IXIARO, the local adverse event rates declined down to about 6% who had any injection site reaction. And as I mentioned before, we don't have these follow-up data for the second dose of Havrix. Now, moving to the solicited reactions, again, within 7 days after each of the vaccinations. Overall, about 40% of children with IXIARO and Prevnar had any solicited systemic reaction within 7 days after the first dose. The dominant symptom was fever in both vaccine groups at about 24-25%. However, the fever was mostly very mild. We see here that only after the second dose of IXIARO, we have one child with a fever greater than 39.4 degrees centigrade. The other reactions that occurred in more than 10% of the study participants in the IXIARO group were irritability and diarrhea, and all other reactions were less common. Again, reactions to the second dose occur at a lower frequency. And these are the respective data for age group 1 to below 18 years of age. Again, we see a comparable rate of systemic reactions to the first dose for IXIARO and Havrix, and fever as the only symptom that occurs in more than 10% of the children. And again, fever is mostly of mild nature, with very few children having higher grade fevers. Now I'd like to move over to look at the serious adverse events in more detail. Again, first looking at infants through to 1 year of age. Up to day 56, we did not have a serious adverse event in the IXIARO group. There was one adverse event in the Prevnar group, a febrile convulsion. And the respective data for the older age group. If you look at the subjects with any serious adverse events up to day 56 on the IXIARO group compared to the Havrix group, these are 4 subjects and 6 subjects for IXIARO and 4 subjects for Havrix, so a relatively comparable rate. The most commonly seen serious adverse events are actually belonging to the groups of infectious diseases. As you can see here, none of these SAEs occurred in more than 1 subject. And if we look at non-infectious disease serious adverse events, the reaction we've seen most commonly was febrile convulsions, and I'll have a slide with more details on febrile convulsions in a moment. So this here looks at the rate of febrile seizures specifically in the children aged between 2 months and through 2 years of age. If we look at the overall rate here, it's 1% or 8 of 771 children in this age range for the IXIARO group, 1.6% in the children who received Prevnar, and 1.4% in the children who have received Havrix. And the chart at the bottom here shows you the timing of febrile seizures. I just would like to point out or remind you of the randomization ratio we had in the study overall of 3:1. So we expect to see more cases here with IXIARO than compared to the control vaccines. But the temporal distribution here does not indicate there would be any clustering of febrile seizures after vaccination with IXIARO. Because the previously used mouse brain-derived JE vaccine had been associated with hypersensitivity reactions, we specifically looked at the rates of adverse events like hypersensitivity or urticaria or rashes that occurred within 14 days after vaccination with IXIARO. And this slide summarizes these data. So we've had a total of 9 subjects who had any such reactions within 14 days after IXIARO. All of these occurred in children who have received the 0.25 ml dose. And I'll walk you through the data in a moment. In the same time frame, we have had 1 subject in the Havrix group with such a reaction within 14 days after vaccination. And while this may appear as a difference, I would actually like to remind everybody that I've showed you before, due to the different number of doses that was administered throughout the trial, we have a much higher cumulative post-vaccination follow-up time here for IXIARO than for the 2 other vaccines. So just keep that in mind when looking at the overall rate of such events. If we look at these reactions in detail, actually there were 3 cases of just rash that occurred within this 14 days window. Actually, all of these 3 cases occurred between 7 and 10 days after the first dose of vaccine. The children were all given a second dose of vaccine, and none of them had a reaction to this second dose of vaccination. There were also 2 other cases of rash, maculopapular and the papular rash, whereas the maculopapular rash was believed to be associated with a probable viral infection. The child had a fever at the same time. There were 2 cases of hypersensitivity. One child who received the hypersensitivity 7 days after the second dose. That reaction was basically not associated with any systemic symptoms, so limited to itching and wheals, and it was self-limited and didn't require any medical treatment. The second case of hypersensitivity, the child received the second dose and did not have any reaction subsequent. There were also 2 reactions of urticaria, one 5 days after the first dose, where the child was given the second dose of IXIARO and did also not have a reaction to this second dose of IXIARO, and then finally 1 reaction 13 days after the first dose. This child was not given the second dose of vaccine, but again, here the investigator believed that the underlying reason for this was most likely a viral infection. So with this, I'd like to summarize and present our conclusions on the data. Overall, the safety profile of IXIARO in children was comparable to the control vaccines, Prevnar and Havrix. The most commonly observed adverse events were in line with the expected adverse event profile in the pediatric population, and most of the adverse events were of mild nature. I haven't shown you the data separately, but especially in the age group 12 to below 18 years, the profile resembled the adverse event profile we know from this vaccine in adults. And compared to Prevnar, IXIARO appeared to cause fewer local reactions. IXIARO was immunogenic at all age groups tested and at both doses tested. The seroprotection rate at day 56 was 99 to 100%, and at month 7 ranged between 85 and 100%. And again, while I didn't show you the data, specifically in the age group 12 to 18 years, the geometric mean titers are comparable to what we see in adults. So with that, I'd like to thank you for your attention, and I'm happy to take any questions.
Thank you. Let's open it up for any questions. Dr. Keitel.
I have two related questions. Can you describe the effect of age and pre-existing immunity on the response to vaccine, and also describe in terms of persistence of antibody, if they have pre-existing antibody, are they more likely to have persisting antibody?
Mm-hmm. Your question is related to the immunogenicity or to the influence on safety, to immunogenicity, okay. I'm just going to go forward and pull up these data by age group. So basically this slide shows you seroprotection rates broken down by age. And as you can see, the results here on, where is it, day 56, we have a very good 100% protection rate throughout all the age groups we have in this study. So looking at 2 to 6 months, 6 to 12 months, we have 99% in the age group 1 to 3 years, and then 3 to 12, 12 to 18, again, are up at 100%. We have a very good persistence with the youngest age groups here at month 7, 100% protection still with the children below 12 months. The 1 to 3 year age groups, we see 85% protection at month 7, and then persistence again appears to be a little bit higher with the older age groups. The respective geometric mean titers are, again, actually we see the best response in the youngest age group. So these are children 2 to 6 months of age who reach the highest geometric mean titers. Although we use the half dose in these pinkish age groups here, we see the titers are best here. And that's the month 7 data, where we also see that persistence is better in the extremes of the age groups. So the very young children tend to keep higher GMTs, and then we see again higher GMTs in the older age group. And that leads over to the basically looking at the impact of baseline JAV immunity. So these are geometric mean titers stratified by pre-existing antibodies. Let me walk you through that slide. It's a little bit complex. Overall, what this compares is the GMTs in children who were seropositive for JEV at baseline. That's 17 with the half dose and 79 with the full dose of vaccine. And they're compared to a group of children who were tested both negative to JEV and also to dengue, which co-circulates in the Philippines. So we see that on day 56, we get lower titers in the children who have pre-existing immunity, both with the 0.25 ml dose of IXIARO here, compared to the 0.5 ml dose of IXIARO. The GMTs are lower in the seropositive at baseline compared to the naives. Looking at the month 7 data, it appears that those who are positive at baseline retain higher GMTs compared to those who are negative at baseline.
Dr. Harrison.
This was an open label trial, but was there any effort to blind the individuals collecting the adverse event data in terms of vaccination status?
No, we have conducted this study as an open label, so the safety data collection and also the immunogenicity data collection was not blinded. We, due to the different number of vaccinations that were given in the study, we would have to have utilized placebo shots just for the purpose of blinding, and we didn't consider it justified based on the fact that we had very robust endpoints.
Dr. Curran.
Could you say something about how the vaccine is supplied, both the 0.25 and the 0.5 dose?
So the vaccine supply will be a single presentation going forward. The vaccine is, I would say, a very niche product for the age groups below 3 years. It's not apparently not routinely given at that age group. So the label of the syringe in the future will carry a mark. And there will be a procedure to expel volume up to that mark and inject the remaining volume as the 0.25 ml dose in children below 3 years.
Dr. Sawyer.
My question relates to the medically attended adverse events, although I certainly see that the rates were similar in the IXARO group compared to both controls. I'm surprised at how high they are. So, for example, in 1 to 18-year-olds, you had for Havrix a 25% medically attended adverse event. That's a vaccine that generally has very few side effects. So is this in any way an artifact of instructions given to the participants in terms of when they should seek medical care, or is this relate to the routine practice in the Philippines, or can you comment further about what types of events led to being medically attended AEs?
Yes. So we believe this is a result of the situation that we're apparently going to a resource-limited country and are offering free medical care for the study participants. So they're probably biased to more likely see a doctor if they have any adverse event. The majority of the unsolicited adverse events that were observed in the study are infectious diseases, and that's certainly also true for the medically attended adverse events. So these are cases of gastroenteritis. We've had children seeking medical attention for things as dog bites, needing rabies shots. So it's that type of adverse reaction, mainly infectious diseases that we're seeing.
Any other questions? Seeing none, why don't we have Dr. Fischer come on up?
Good morning. So on behalf of the JE vaccine work group, I'm going to present the GRADE evidence and the proposed recommendations for the use of JEVC in children. Just to review, in March 2009, IXIARO or JEVC was licensed for use in adults in the United States, Europe, and Australia. And in June of that same year, ACIP approved the current recommendations for the use of JE vaccine in travelers. Those recommendations included JEVC for adults 17 years of age or older, and the inactivated mouse brain-derived JE vaccine, or JEMB, for adults and children 1 year of age or older. As we've heard, JEMB is no longer produced, and no JE vaccine has been licensed and available for children in the U.S. for the past 2 years. And last month, JEVC was licensed for use in children 2 months of age or older. The work group evaluated the evidence for use of JEVC in children using the grading of recommendations, assessment, development, and evaluation, or as we've come to know it, GRADE methods. We developed a policy question, identified outcomes of critical importance, performed a systematic review of published and unpublished data, and evaluated evidence of benefits, harms, values, and costs before formulating recommendations for use of JEVC in children. The policy question considered by the work group was as follows. Should JEVC be recommended for use in children 2 months through 16 years of age at increased risk of travel-related exposure to JE virus? The population includes children 2 months through 16 years of age traveling to JE endemic areas. The proposed intervention is JEVC administered in a 2-dose primary series, And as mentioned, no JE vaccine is currently recommended and available for use in children. Next, we surveyed the work group to identify and rank the outcome measures to be evaluated. As this slide shows, the work group identified vaccine efficacy and seroprotection at 1 and 6 months as benefits of critical importance. However, there are no efficacy data for JEVC. A JE virus plaque reduction neutralization test, or PRNT titer of 10 or greater, is an established immunologic correlate of protection, and that was used to evaluate evidence of seroprotection. The harms considered, critical outcomes were serious adverse events and systemic adverse events. The FDA definition for serious adverse events was used. Systemic adverse events evaluated included fever, rash, hypersensitivity or urticaria, neurologic adverse events, and medically attended adverse events. Injection site reactions and interference with other vaccines were considered important outcomes but were not included in this grade evaluation. To collect the evidence for the grade evaluation, we performed a systematic search and review of the published literature. We identified 12 studies that reported primary data relative to the critical outcome measures, including the 1 study in children that's published and 11 studies in adults. We also reviewed unpublished data. This included 2 clinical trials of JEVC in children, which you've just heard about, VAERS reports for JEVC administered to adults in the United States or U.S. military personnel, and 2 clinical trials of similar inactivated Virocell-derived JE vaccine, which is manufactured and licensed in India under a trade name JEEV. I will now summarize the relevant evidence for each of the critical outcomes. The evidence used to evaluate seroprotection at 1 month after vaccination with JEVC was from 10 studies, including 3 in children and 7 in adults. This table shows the 3 pediatric studies which were just presented by Dr. Dubischar-Kastner, including the randomized controlled trial in children 1 and 2 years of age in India, the randomized controlled trial in children 2 months through 17 years of age in the Philippines, and an observational study in children 2 months through 17 years of age in the US, Europe, and Australia. The study in the Philippines provided no comparative immunogenicity data, so for this part of the evaluation, it was considered observational. Of the 578 children who received JEVC in the 3 studies combined, 99% were seroprotected at 1 month after the 2-dose primary series. Of the 7 studies in adults with seroprotection data at 1 month, 5 were randomized controlled trials and 2 were observational studies. However, again, 2 of the randomized trials had no comparative immunogenicity data and were considered observational studies for this analysis. The comparator JE vaccines used in the controlled trials included an inactivated mouse brain-derived vaccine from Korea and one from Japan, and the JEV vaccine from India. Of the 800 adult JEVC recipients in the 7 studies combined, 98% were seroprotected at 1 month after the 2-dose primary series. This slide shows the results of a weighted random effects model combining data from the 4 randomized controlled trials in both children and adults. The proportion of subjects with neutralizing antibodies are repeated from the previous slide. Risk ratios and 95% confidence intervals are calculated to compare seroprotection rates in JEVC and the comparator JE vaccine recipients. The risk ratios from individual clinical trials are weighted and combined to provide an overall comparison from the 4 studies stratified by children and adults. The risk ratios and confidence intervals are plotted on the right. The blue squares and black lines display results from a single study. The black diamonds display combined results for children, adults, and then overall. And in this figure, results to the right of the vertical line favor seroprotection in JEVC recipients, and results to the left of the line of the vertical line favor seroprotection rates for people who received comparative vaccines. Overall, there was no difference in seroprotection rates at 1 month between JEVC and the other JE vaccines. Moving on to 5 to 6 months, the evidence used to evaluate after that was from 4 studies, including 2 each in children and adults. For the pediatric studies, follow-up was at 6 months after completing the 2-dose primary series. For the studies in adults, the follow-up was at 5 months after completing the 2-dose series or 6 months after the first dose. Of the 800 JEVC recipients in the 4 studies combined, 90% still had PRNT titer of 10 or greater at 5 to 6 months after the 2-dose primary series. This included 89% of 500 children and 90% of 297 adults. The findings from the 1 randomized controlled trial in adults showed that a significantly higher proportion of JEVC recipients were seroprotected at 5 months following vaccination compared to subjects who received the mouse brain-derived JE vaccine. The evidence used to evaluate serious adverse events within 56 days after the first dose of JEVC or control vaccines was from 13 studies, including 11 clinical trials or observational studies in children or adults, and 2 reviews of post-marketing surveillance data in adults. This table summarizes the data from the 3 pediatric studies. As previously presented, the control vaccine for the study in India was an inactivated mouse brain-derived vaccine from Korea. The control vaccines in the Philippines study, as we just saw, were hepatitis A and pneumococcal conjugate vaccine. Serious adverse events were reported in less than 1% of the 1,519 children who received JEVC overall. No serious adverse events were reported during the studies in India or among the children from non-endemic countries. 6 serious adverse events were reported from the 1,411 children who received JEVC in the Philippines study. These included 2 febrile seizures and 1 report each of cellulitis, gastroenteritis, pneumonia, and dengue. In the 7 clinical trials in adults, serious adverse events were reported in less than 1% of 2,874 JEVC recipients within 56 days after the first dose. The control vaccines in the various studies included mouse brain-derived JE vaccine from Japan and Viracell-derived JE vaccine from India, hepatitis A vaccine, as well as a placebo of phosphate buffered saline with aluminum hydroxide adjuvant. This figure shows the weighted random effects model combining the data from the 7 randomized control trials in both children and adults. The results now to the left of the vertical line indicate fewer adverse events in JVC recipients. Results to the right of the line indicate fewer events in people who received control vaccines. Overall, there was no difference in serious adverse events reported in the 56 days after the first dose of JEVC or the comparison vaccines. 3 studies provided data for serious adverse events within the 6 to 7 months after the first dose of JEVC or the control vaccines. In the 2 pediatric studies, a total of 1,471 children were followed for 7 months after the first dose of JEVC. Of these, 25 children, or 2%, had serious adverse events reported. In a study which pooled clinical trial data from adults, 1% of 3,558 JEVC recipients had serious adverse events reported within 6 months after their first dose. Again, there was no difference between JEVC and comparison vaccine recipients in serious adverse events reported within 6 to 7 months post-vaccination in the 2 randomized controlled trials in children or adults. 2 studies evaluated serious adverse events were reported to passive post-marketing surveillance systems following the receipt of JEVC, all in adults. The first is a published study which included reports from the US, Europe, and Australia for April 2009 through March 2010, during which time approximately 250,000 doses of JEVC were distributed in these areas. The second study includes unpublished VAERS data from May 2009 through April 2012, when more than 275,000 doses of JEVC were distributed in the US alone. Approximately 85,000 doses distributed in the US from May 2009 through March 2010 would be included in both of these surveillance systems. However, there was no overlap in the 13 serious adverse events identified in the 2 separate analyses. The relatively small number of subjects in the clinical trials limited the ability to detect rare serious adverse events. However, these post-marketing surveillance data from more than 400,000 doses distributed provide some indirect but reassuring data in adults, with 1.6 to 3.3 serious adverse events reported per 100,000 doses distributed. There were no patterns in the timing or types of serious adverse events that were identified in either the clinical trials or these surveillance data. The evidence used to evaluate systemic adverse events following JEVC was from 9 studies, including 7 clinical trials or observational studies, and then the 2 reviews of post-marketing surveillance data that I just discussed. This slide shows fever as a solicited event within 7 days after JEVC, which was reported in 6% of 3,659 subjects in 6 clinical trials, including 9% of about 1,500 children and 4% of 2,140 adults. When data from the 4 randomized controlled trials were combined and weighted using the random effects model, there was no difference in the incidence of fever between recipients of JEVC or the control vaccines. Rash as a solicited adverse event within 7 days of either JEVC dose was reported in 2% of all subjects, including 3% of children and 1% of adults. Again, for rash in the 4 randomized controlled trials, there was no difference in the incidence between JEVC and comparison vaccines. Hypersensitivity or urticaria within 56 days of the first dose of vaccine was reported in less than 1% of 3,635 JEVC recipients in the 5 studies combined. In the 3 randomized controlled trials, there was no difference again in the incidence of hypersensitivity reactions between JEVC and control recipients. Neurologic adverse events, excluding headache, were reported in 1% of JEVC recipients within 56 days after the first dose of vaccine. There were no cases of meningitis, encephalitis, or Guillain-Barré syndrome reported among JEVC or control recipients. The 5 neurologic events reported following JEVC included 3 febrile seizures in children 1 to 2 years of age at 2 days, 8 days, and 2 weeks after vaccination. 1 child 1 to 2 years of age who had drooling, and 1 child 3 to 11 years of age who had dizziness. And again, there was no difference in the incidence of neurologic adverse events between JEVC or control vaccines. Medically attended adverse events were reported in 14% of 3,714 subjects overall, but ranged from 18% in 1,471 children to 12% of 2,243 adults. When data from the 3 randomized controlled trials were combined and weighted in the random effects model, there was no difference in the incidence of medically attended adverse events between JEVC and comparison vaccine recipients. In the 2 reviews of post-marketing surveillance data, the reported incidence of hypersensitivity in adults was 4.5 to 4.7 per 100,000 doses distributed. 13 hypersensitivity reactions reported to VAERS occurred within 14 days after vaccination. However, 7 occurred after administration of JEVC alone, while 6 occurred after concomitant administration of JEVC and other vaccines. 5 neurologic adverse events following administration of JEVC in adults were reported to VAERS for a total incidence of 1.8 per 100,000 doses distributed. These included 1 report of encephalitis at 39 days after vaccination with JEVC and 4 other vaccines, and then 4 reports of seizures within 5 days after vaccination. 3 of the JEVC recipients with seizures had received other vaccines, and for 1 there was no information available. In addition to the studies of JEVC in children and adults, we reviewed evidence for seroprotection, serious adverse events, and systemic adverse events from a randomized controlled trial of a similar JE vaccine, which is manufactured and licensed in India under the trade name JEV. JEV is manufactured by Biological E using technology transferred from Intercell. JEV is licensed in India for use in children age 1 through 2 years of age and adults age 18 through 49 years. JEV and IXIARO use the same virus strain, adjuvant, and virus purification steps. However, no process comparability studies have been completed, and it cannot be assumed that the 2 final vaccine products are the same. In 1 randomized controlled trial comparing JEV and a mouse brain-derived JE vaccine in children aged 1 through 2 years, 92% of the 280 children who received JEV had protective neutralizing antibodies at 1 month after the second dose. Serious adverse events were reported in less than 1% of recipients, and fever within 7 days after either dose was reported in 11% of children, and rash in 1%. Although JEV and JEVC are not identical vaccines, these data provide some additional evidence of immunogenicity and safety of inactivated vero cell culture-derived JE vaccine in children. After completing this review and summarizing the data, we assessed the quality of the evidence for each of the 4 critical outcomes. We used the standard grade classifications with the initial evidence type classified based on the study design, with randomized controlled trials or overwhelming evidence of observational studies considered evidence type 1. RCTs with important limitations or exceptionally strong evidence from observational trials were classified as evidence type 2. Observational studies or randomized controlled trials with notable limitations were classified as evidence type 3. And clinical experience observational studies with important limitations, or RCTs with several major limitations, were classified as evidence type 4. The evidence type for each critical outcome was derived through a review of the study design and limitations, including risk of bias, inconsistency, indirectness, and imprecision. For seroprotection at 1 month post-vaccination, 4 randomized controlled trials started at evidence type 1, but were downgraded because of indirectness due to the majority of the data being in adults for a final evidence type of 2, shown here. The 6 observational studies for seroprotection at 1 month started at an evidence type of 3, and no additional serious limitations were identified. For seroprotection at 6 months, there was 1 randomized controlled trial and 3 observational studies. The RCT was again downgraded to evidence type 2 because of indirectness, and no serious limitations were identified in the observational studies. Other criteria that were considered but had no effect on evidence type included publication bias, strength of association, dose response, and residual confounding. For serious adverse events, 8 randomized controlled trials started at evidence type 1, but were downgraded because both risk of bias due to inadequate blinding and indirectness due to the majority of data being in adults for a final evidence type of 3. 5 observational studies started at evidence type 3 and were downgraded to evidence type 4 because of indirectness. For systemic adverse events, the evidence provided by 5 randomized controlled trials were downgraded to type 2 because of the risk of bias, again due to inadequate blinding. 6 observational studies started at evidence type 3, and no serious limitations were identified. This table shows the overall quality of evidence for JEVC in children. Both RCTs and observational studies were considered in the overall body of evidence, but the final evidence type was based on the RCTs, which provided the higher quality of evidence. The overall quality of evidence was classified as type 2 for vaccine safety and vaccine effectiveness using seroprotection as the endpoint. After establishing the quality of evidence, the next step was to assess the values and preferences related to management options and outcomes. For most travelers to Asia, the risk for JE is very low, but varies based on destination, duration, season, and activities. More than 300 cases of JE were reported among U.S. military personnel during the Vietnam and Korean Wars. However, for the 40 years from 1973 through 2012, only 65 cases of travel-associated JE among people from non-endemic countries have been reported to CDC or published in the literature. 6 of these cases occurred in children. This graph shows the year of disease onset for travel-associated JE cases reported from 1973 to 2012. The adult cases are shown in red and the pediatric cases in yellow. During this time, there was a median of 1 case reported per year with a range of 0 to 6 annual cases. Of the 65 travel-associated cases reported during this time, 20% were fatal, and 43% of the patients survived with neurologic or cognitive sequelae. Among the 6 pediatric cases, 2 were fatal, 3 survivors had sequelae, and 1 patient had an unknown outcome. For 47 of the 65 travel-associated cases, more complete information was available regarding their itineraries and activity. Duration of travel for these cases ranged from 10 days to 34 years, and 64% of the cases were traveling for a month or longer. Of the 17 shorter-term travelers, 13 had a trip duration of 2 to 4 weeks, and 4 had traveled for 10 days to 2 weeks. Among these shorter-term travelers, 4 had known extensive rural exposures, 10 took shorter trips to rural areas, and 3 stayed primarily in coastal areas. There were no cases reported among short-term travelers who visited only urban areas. Of the 65 reported travel-associated cases, 19 occurred in U.S. travelers or expatriates, including 3 of the pediatric cases. However, a JE vaccine has been available in the United States since 1993, and it is not known how many cases have been prevented due to vaccination or how many cases are not diagnosed or reported. In addition, the numbers of susceptible travelers to JE endemic areas is also unknown, and these limitations make it difficult to estimate the overall risk of JE among travelers to Asia. Recommendations regarding the use of JE vaccine for travelers must weigh the risks of travel-associated JE with the benefits and potential risks of JE vaccine. The overall risk of JE for travelers is very low. When JE does occur, however, it has a high morbidity and mortality, and there is no treatment. A safe and effective vaccine is available. The vaccine is relatively expensive, and the possibility of rare serious adverse events cannot be excluded. Finally, because humans are not amplifying hosts, JE vaccine protects the person who receives it, but does not prevent importation or spread of the virus. The work group placed a high value on preventing a life-threatening disease with no treatment options. We noted that a survey performed in the United States in 2001 found that parents and community members were willing to pay a median of $500 to reduce the risk of bacterial meningitis from 21 to 6 per 100,000. Although the rates of disease used in the survey are higher than the risk for JE among all travelers to Asia, these findings support a willingness to pay to prevent a serious outcome. The work group also placed a high value on educating healthcare providers to help them counsel travelers about JE and JE vaccine, and to inform decisions about JE vaccination based on a traveler's planned itinerary. The work group also considered the costs of JE vaccine for children. Several studies have demonstrated that using JE vaccine to immunize children in JE endemic countries is cost savings. However, given the large numbers of travelers to Asia, the low risk for JE for most travelers, and the high cost of JE vaccine, providing JE vaccine to all travelers to Asia would not be cost effective. In addition, for some travelers, even a low risk of serious adverse events attributable to vaccine might be higher than the risk of disease. Therefore, JE vaccine should be targeted to travelers who are at increased risk for disease based on their planned itinerary and activities. The number of U.S. children who travel to Asia and have itinerary that puts them at increased risk for JE is likely very low. In addition, travel vaccines are usually paid for by the travelers themselves. They are not covered under the Vaccine for Children's program or by most private insurance plans. As a result, the work group decided not to perform a cost-effectiveness study of JE vaccine for U.S. children travelers to JE endemic countries. The work group considered the following findings from the GRADE evaluation in formulating our proposed recommendations. JEVC provides high levels of seroprotection in children following a 2-dose primary series. Serious adverse events are uncommon, and rates are similar to those seen with comparison vaccines. Systemic adverse events also occur at rates similar to comparison vaccines. There was a high value placed on prevention of a serious disease with no treatment and substantial morbidity and mortality. However, the overall low risk of disease, low risk of vaccine-related adverse events, and high vaccine cost warrant targeted vaccination of higher risk travelers. Given these considerations, the work group came to the following conclusions and recommendations. JEVC is effective using seroprotection as the endpoint and safe in children aged 2 months through 16 years of age with an overall evidence type of 2. Based on the GRADE evaluation for JEVC, the work group found no reason to change the existing recommendations which were approved in 2009. Therefore, the work group proposes to extend the current ACIP recommendations for use of JEVC to include children greater than or equal to 2 months of age. No other changes to the existing recommendations are proposed. The recommendations and grade categories, therefore, are as follows. JE vaccine is recommended for travelers who plan to spend a month or longer in endemic areas during the JE virus transmission season, This includes long-term travelers, recurrent travelers, or expatriates who will be based in urban areas but are likely to visit endemic rural or agricultural areas during a high-risk period of JE virus transmission. This recommendation was given a category of A. In addition, JE vaccine should be considered for short-term travelers to endemic areas during the JE virus transmission season if they plan to travel outside of an urban area and have an increased risk for JE virus exposure. For example, spending substantial time outdoors in rural or agricultural areas, participating in extensive outdoor activities, staying in accommodations without air conditioning, screens, or bed nets. JE vaccine also should be considered for travelers to an area with an ongoing JE outbreak and travelers to endemic areas who are uncertain of specific destinations, activities, or duration of travel. This recommendation is given a category B. Finally, JE vaccine is not recommended for short-term travelers whose visit will be restricted to urban areas or times outside of a well-defined JE virus transmission season, and this is also category A. So following questions and discussions, we propose a vote on extending the current ACIP recommendations for use of JEVC to include children 2 months of age or older. There will not be a VFC vote as discussed. And with that, I'd like to thank Dr. Bocchini and Dr. Rubin and the other work group members for their substantial time and efforts. Thank you.
I'd like to thank Dr. Fischer and the work group for an incredibly clear, beautiful presentation of this evidence and recommendation using GRADE. It almost felt routine here, but it was just the presentation that makes it incredibly easy to follow and very, very nicely done. Dr. Keitel.
Two related questions. Does your recommendation include any additional comment about the need for booster immunization, number one? And number two, are there any data from endemic areas that just the primary series is necessary to protect an individual over the long term?
Okay, so regarding the first, there are current recommendations that ACIP passed in 2011 regarding a booster dose for adults, which will remain in place. We don't have data at this time to address a booster dose for children. There are studies that are ongoing for that, so at this point we're only asking for recommendations for the primary series, 2-dose primary series. We will need to address booster dose for children. Regarding duration of protection in endemic areas is a little more difficult to answer. One, because there are, as we heard, various JE vaccines that are licensed and used in Asia, which are different. There's a live attenuated vaccine that appears to provide long-term protection. Regarding inactivated vaccines, the most commonly used ones have been mouse brain-derived vaccines, and those have required subsequent booster doses. Regarding the inactivated vaccines, virocell-derived vaccines, they haven't been really in use long enough to know full duration of protection or numbers of booster doses that would be needed.
Dr. Harrison.
Mark, are there any data on the immunization status of the travel-related cases?
As far as we know, for the 65, they were all reported to be unvaccinated. And again, those are all published or reported to CDC, so there's fairly extensive evaluation of those.
Dr. Harriman.
Is this vaccine recommended for certain child travelers in other non-endemic countries?
Yes, so the vaccine is approved for use in Europe and Australia, and is recommended in those countries for use in those travelers. They vary between the exact recommendation, so it's licensed for the same dose, same indication. The recommendations are slightly different, but it's recommended for travelers, pediatric travelers in those countries.
Dr. Dushan.
Thank you for the presentation. Mark, I'm wondering if you can just expand a little bit on the rationale that the working group used to derive the Category B recommendation for the short-term travelers. 35% of the cases were in short-term travelers, and I'm just wondering a little bit more about why that wouldn't be in a category, have the same strength of recommendation as the others.
Right, thank you. So maybe we can go back to that. So this goes back to the discussion that was had several years ago when we discussed the vaccine for adults, and really we came to the same conclusion. So 2/3 essentially of the travelers had prolonged duration of travel or were expatriates. And then again, 1/3 had shorter term travel. However, even among the shorter term travelers, they essentially have some type of risk factor in almost all cases that you can identify. A quarter of those shorter term travelers alone had extensive rural travel, and then the others had shorter term travel to rural areas. So we really felt it was important to divide the people who were at highest risk. You know, it's not ideal, but based on duration of travel, and then give the sort of ability for the healthcare provider to have information that they can assess the risk for the largest group of travelers who may be spending shorter periods of time, but distinguish those travelers who are just going to urban areas versus shorter areas, rural areas. So we made that distinction.
So just following up, it looks like the recommendation is though even if you identify a short-term traveler going to high-risk areas, it's still a Category B.
That's right. It's a Category B because you have to make that consideration. That's what Category B, I believe, is that the healthcare provider needs to evaluate the patient's itinerary and assess their activities to make that determination. So that's part of so it's not a recommended for all people who are shorter term. It's a consider the vaccine and assess what their risk factors are.
So why not explicitly state that if you're a short-term traveler going to a high-risk area, based on the criteria you described, they should be Category A?
Well, I think this is it depends how many groups you want to split out. I think we decided to split out, again, this discussion was held mostly under the adults and then held the same for children, split out based on the clearest identified risk being duration of travel to make a recommendation for all of those travelers, then allow healthcare providers to have the information to consider, which is a Category B recommendation for the other shorter term travelers, and make that determination based on their activities.
Other questions? Dr. Baker.
So following up on Dr. Dushin's comment, should be considered is really difficult for physicians to deal with. So I don't disagree in any way with where you've come with a Category B based on the rules of grade. Maybe rules is too strong. But I think that it should be very clear in whatever you say that if you fall in this situation, the pediatrician provider, because we're talking about children, or family practitioner, really needs to understand that you should give the vaccine. So I find should be considered one of these waffling phrases. Whenever we put it in the Red Book, I get calls about it. As Dr. Pickering knows, so does he.
Dr. Quinn Beasley.
Another comment related to the recommendations that I think would provide some clarity for practicing providers is defining kind of, we say a number of times during the JE virus transmission season, and the provider in practice may not know exactly when that season is, and so perhaps giving some guidance about that season time frame would be helpful.
And that information is provided in the recommendations and in the Yellow Book, which the people are referred to. So the Yellow Book, which is the International Health Travel Recommendations from CDC, has a table by country that gives recommendations for both the season and the areas that are risk. And that is referred to from the recommendations that are published.
Dr. Turner.
Jim Turner, American College Health. I actually really wanted to direct a question to our insurance representative. One of your slides indicated that private insurance plans generally don't pay for these travel vaccines, but as I understand it, under the Affordable Care Act, preventive services, including vaccinations, are now supposed to be included, and I'm not aware that travel vaccines are excluded from that, and I'm wondering also the Medicaid population as well. So can you clarify that?
I'm actually not able to clarify that specifically today. Actually, as far as coverage, where this is involving travel by the insured, by the employer, it is generally covered. I'm going to have to clarify regarding the Affordable Care Act whether this is also covered under that rule.
The reason I bring it up is it clearly has cost implications for third-party payers and government agencies if in fact they have to cover it. And we're preventing 1 or 2 cases a year, it looks like, from your data.
Yeah, Ann or Kristen may want to comment on the Affordable Care Act, but I think the vaccines in there are vaccines that are in the recommended tables, the childhood and adult immunization tables, and this will not be in there. Is that
Dr. Lair?
Jamie Lair from the AAFP. I would suggest that for the slide that's up in front of us right now, there's 2 sentences, and the first sentence, I would agree with Jeff Dushan that we could change to JE vaccine is recommended for short-term, et cetera, all the way down to that period, and make that a category A, and only leave the second sentence as a category B.
Dr. Grog.
Stan Grog from the American Osteopathic Association, but I'm speaking from a person that's got a travel medicine certificate, and we have a travel medicine clinic. Typically, JE is not reimbursed by insurances. It's not inexpensive. It's rather expensive. But companies will pay if they're sending somebody to those areas for work-related, but insurance typically does not pay for it.
Dr. Smith.
Jean Smith, ACIP Medical Officer. This is relating to the implementation and insurance questions. When we were first talking with Dr. Fischer about this, we did learn that as far as the Affordable Care Act, that covers routinely recommended childhood vaccinations, not travel vaccinations. And secondly, I just had some personal experience with this because I just put my 15-year-old daughter on a plane to Nepal, where she is now. So I investigated this in depth, including talking with Dr. Fischer, and indeed discovered the serious costs about $500. Private insurance doesn't pay for it. My daughter belongs to a large pediatric practice in Atlanta who doesn't even offer the vaccine. I got in touch with a travel clinic to follow up. But maybe some of the people like Dr. Grog and Dr. Gershman know, is it really likely that a general practicing pediatrician will be called upon to give this vaccine and therefore interpret the recommendation, or is the child more likely to be going to a specialized travel medicine clinic who really knows how to interpret?
Dr. Grog and then Dr. Sawyer.
Yeah, typically they would go to a travel medicine clinic because if they need Japanese encephalitis, they're probably going to need other things such as yellow fever, which has to be a CDC certified clinic.
And Dr. Sawyer.
Yeah, I don't see how the recommendation Dr. Lair made confuses things, so I would like to make a motion that we accept the recommendation as presented with the change that Dr. Lair recommended, that this first sentence become category A and the second sentence remain category B.
And I think I would add to that, just to be consistent with discussion in the past wording, the second sentence probably should read, JE vaccine may be used. As I think we try to get away from should be considered as a phrase, and instead under category B it's may be used. Dr. Dushan? Okay.
Can we clarify a point about if we're going to vote on this?
Yeah.
Because these are the recommendations for adults currently, and we were voting on recommendations for children. So the question would be if we made any changes to these recommendations, the ACIP saying that we're changing the recommendations for adults, which was not, we didn't complete the review for that purpose. So that could be done, but the committee needs to know that would apply then to adults as well as children, which would be a change from their current recommendations.
Dr. Harrison.
But let me ask the question, given the discussion, why should we not change the first be considered to is recommended and be category A?
Dr. Shukat?
Yeah, I vaguely recall this being discussed when we were dealing with the adults, but since some of the discussion is focusing in on this 1/3 of the cases occurring in people who have the short-term exposure, I wonder if somebody could remind us about the denominator and what proportion of travelers are short-term versus long-term, because I believe part of this was about really focusing in on a small population that you could try to get adherence to and have the permissive recommendation where you have to do additional fact-finding relate to the larger group. So maybe you have the data?
Yeah, I don't have them up here. I presented them in February. There really aren't very good data that allow us to distinguish that. Most of the data on travelers are based on entries to Asian countries. We did do a survey at airports where we asked people about their itineraries, their planned duration of travel, and what they were going to do there. And based on that, about a quarter of the travelers that we surveyed at the 3 airports in the United States had either intention of long-term travel or spending the majority of their time in rural areas. So it was a relatively small survey. I don't remember the numbers, but hundreds of people. There are millions of U.S. travelers who enter Asian countries, so as you say, that was our attempt to really focus in on the people that we believe were at the truly increased risk of disease. But those are the only data I'm aware of that allow us to try and get an idea of that denominator who would meet that higher risk category.
I think the comments of Dr. Smith and Dr. Grog are very germane here because of the fact that most clinical practices don't keep this vaccine available, and it really goes into that realm of travel medicine. The other point is I think the work group tried to harmonize this with the pre-existing adult recommendation. Dr. Bocchini.
Yeah, I'd just like to reiterate that point that we wanted to be very careful not to change the adult recommendations while we were making the recommendations for children, and felt that the language of this current recommendation that's up on the screen really is more of a category B type recommendation based on the language that we now use to make our recommendations. And so that's why, in fact, there was one point where we actually split these 2 sentences and had separate recommendations and put them back together because that's really what's in the adult recommendations. So just as background, we did try and deal with this issue and came back to this approach.
Dr. Dushan.
So recognizing the consistency issue, would it not be an improvement, though, to take that group for which group of travelers who are going to be short-term but at high risk, for which my impression is the committee or the work group would recommend the vaccine. We would want them to get that vaccine, not just consider it and maybe give it, maybe not, but we want them to get it, to put them in the category of the other people who we want to get it.
We wanted people to consider the circumstances to make the decision. So I think, okay, so then maybe over time that language needs to change to reflect that. But
Yeah,
the key is to consider the circumstances to make that decision.
I think if you look at what that language includes, it includes a pretty wide range of different travelers who have very short-term travel and are going one day to a rural area versus people who are traveling for 2 weeks, and that's how we felt there was variation. Regarding the wording should be considered, this was prior to grade recommendations and prior to language, so whether that wording should be used or not, but that was the rationale, at least at the time when these were passed.
Dr. Bennett.
I wonder if this could partly be addressed by creating an algorithm that would be easy to follow for anyone who was trying to decide whether to give this vaccine or not, and in the algorithm be a bit more specific about what the criteria are for choosing to give the vaccine.
Other comment, questions? Anyone willing to make a motion? Okay, then we need a second, Dr. Dushan. And just point of order, is the motion for the recommendation as it is laid out here?
Well, I need guidance on that. I made the motion thinking about the childhood recommendation, so I didn't consider that the adult recommendation would then be different, so I'm not quite sure how to handle that. My personal preference is that we change it for both, but I don't know if we should or can do that in this session.
Dr. Coyne-Beasley?
Hi, I'm chair of the adult working group, and I think it would be inappropriate to change the adult vaccination recommendation without consulting that group.
Willingness to modify the motion?
Yeah, I think in that light, I think I would modify the motion to just accept the language as presented here for children, and that this discussion move forward in the JE work group and the adult work group for possibly changing both later.
And is that acceptable to you, Dr. Dushan? Okay. Anyone else to second?
Second.
Dr. Campos outcalled seconds. Other discussion? Oh, Dr. Bocchini.
Let me just mention that the next task, I think, for the work group is to update the guidelines to redo the statement for JE vaccination. And I think the comments that are made and the questions that were raised, I think will help us in reformatting this bullet or this recommendation so that it reads more towards what you suggest. And so I think and I think the algorithm would help as well. And I think we can look for those to help try and clarify this in the future when the new recommendations come through the committee.
Thank you. Dr. Lehrer.
Two comments. Did you want to change the should be considered wording? I thought that was something that Dr. Temte brought up. And the second comment is the way this is phrased has no comments regarding adult or pediatrics. So I'm not sure if there's a header somewhere that says this is only for pediatric recommendation, but this is just any vaccine traveler, any traveler to the area.
Well, essentially, we're just extending the age group for the recommendations so that there will be a policy note that will define that the age group has been extended, but the recommendations will stay the same.
Correct. Yeah, to put it in, again, when these were passed, there were 2 vaccines that were licensed for use in different age groups. So basically, in the current recommendations, that's covered under each vaccine, stating it's licensed and recommended for use in this age group versus that. So currently, these recommendations apply to the 2 different age groups. We will extend that, and in the policy note, it will note the licensure. And I might say the reports and recommendations do also have a box. I'm not sure it's quite an algorithm, as Dr. Bennett referred to, but there is a box that delineates the sort of recommendations and then the consideration categories that provide essentially that type of detail.
Dr. Dushan?
So just to clarify, I'm a little confused. If this language applies to both adult and pediatrics, what is the barrier to changing the recommendation to indicate that people who are short-term travelers at high risk should get vaccinated, if that would cover both populations anyway?
Yeah, there's not a barrier, but the vote was for extending the use of the vaccine in children. That's what was presented. That was the vote. I just wanted people to be aware that if you did vote on that, that would be changing the recommendations for adults, or we'd have different recommendations for the 2 age groups.
I see, but is it, I mean, there's no reason not to make that same change for adults, is there?
I think that's up to ACIP to decide that. But they have these are the existing recommendations that this committee voted on 2009 for use in adults. So you would be, unless you wanted to have different recommendations for the 2 age groups, if you voted on that we would apply it to adults, and that would need to be then published in that way. Otherwise, we would just publish a policy note saying these recommendations are extended to the use in children.
And I believe the comments of Dr. Coyne-Beasley and Dr. Bocchini are appropriate here in terms of taking this back to the work group, considering making, here I'm using the word too, making that change to maybe used, for example, and also moving that first sentence into the recommended and returning this to the full ACIP perhaps at the next meeting. Dr. Keitel and then Dr. Campos-Outcalt.
Well, I guess I'm confused too, because to a certain extent, it depends on whether we all agree that short-term travelers to high-risk areas during the season of transmission would make us say you should receive the vaccine. That, to a certain extent, that's what we're saying. I appreciate Dr. Schuchat's comments about we lack the denominator data, because it may be that almost everybody goes short-term and it's a minuscule risk and we wouldn't recommend it, but I'm not sure that's how the people around the table feel. If you're really going to a high-risk area where there's transmission occurring, would you, in your algorithm, say that person should get the vaccine?
Dr. Campos-Alcolt.
Yeah, I think it is a B. To me, I mean, first of all, high risk is kind of a relative term. I'm not sure I'd use high risk. I would say higher risk, because it appears that high risk, that it's pretty low risk regardless. So to me, this is a B recommendation, where you really want to consider your circumstances, what kind of risk you might be at, get the best available data, look about how else you can protect yourself, and then make a decision whether you want vaccine or not. To me, I don't think I would recommend everybody who meets that definition get the vaccine. So I think it is a B.
Dr. Harrison.
I like the idea of extending the age range today, having that vote, and then readdressing this at the next meeting. I don't think we can resolve it now.
Other comment? We have a motion and a second as it stands, and I believe we can start out with a vote, and we'll, Dr. Bennett.
Can you just clarify one thing? There was discussion of changing the wording, and I just want to be clear, are we voting on the wording as it currently exists or with change?
We're voting on the wording as it is presented in this slide and in the other two slides as well. I think we're going to, the question is changing it may be used, and I think at this point in time for harmonization between the existing JE adult recommendation and this one, we keep the wording as such and have that brought back at a future meeting. Dr. Curran.
No, I guess I'm just wondering, I appreciate all of the discussion, but I don't know why we wouldn't change this to maybe use now, since that's the kind of language we're hoping to use for the future.
And the question is whether or not we could live for 4 months with maybe, or should be considered or not, and bringing that back. To be honest, I can live either way.
But I do think, I'm sorry, I do think the importance of harmonization is significant. In a vaccine you're not going to give very often anyway, and, you know, who wants to make people crazy?
The nice thing here is we're quibbling over minor little language points as opposed to the bigger picture. And again, I think that is testimony to how nicely the evidence was presented to ACIP. So again, thanks to Dr. Fischer. Are there other comments? Hearing none, may I pick on Dr. Sawyer? And let's go counterclockwise.
Sawyer, yes.
Vasquez, yes.
Queen Beasley, yes.
Rubin, yes.
Duchin, yes.
Harriman, yes.
Bocchini, yes.
Harrison, yes.
Karen, yes.
Keidel, yes.
Tempte, yes.
Bennett, yes.
Campos-Alcolt, yes.
And the motion is approved unanimously. And I believe we have earned break time.